All right, it's noon. Good afternoon, everyone, and thank you for joining us for our webinar today. We're excited to welcome Catherine Hu and Rana Modir to the program. They'll present on the application of telehealth in nutrition. We've reserved some time at the conclusion of their presentation for questions and discussion. I'm also fortunate to have here today Professor Lika George. Thank you, Dr. George. And joining us later is Dr. Dustin Neal, the Trauma Medical Director and CQ Director at the University of Missouri, Kansas in Kansas City. Dr. George?
This educational activity is a project of the Texla Telehealth Resource Center, a federally funded program in the F. Murray Hall Institute of Rural and Community Health at the Texas Tech University Health Science Center. Texla collaborates with a Well Ahead Louisiana in the Louisiana Department of Health and is a proud member of the National Consortium of Telehealth Resources, as well as SCCM Surgery.
Well, I'm waiting for Dr. Neal, but while Dr. Neal is not here, this CME credit is available for participants of this webinar, and a link to take the survey will be provided at the end of this presentation and will be emailed to the attendees, so make sure you fill that up. There are just some helpful tips for our webinar today to ensure that you can receive your CME credit if so desired. Please make sure everyone is muted. And please type any questions or comments you have during the presentation into the chat box. We will now introduce our esteemed speakers. Dr. George?
Yes. Today we have Catherine here, and she is a certified diabetic care and education specialist and a registered dietitian at Stanford Endocrinology Clinic and Diabetes Care Program. She helps patients on one-on-one basis and leads group classes both in person and through telehealth. Welcome today.
You can do that. You can All right, let's make sure everyone is muted. Rana Modir is a clinical dietitian for over 10 years.
Santa.
Oh, there you go, Dr. Neal. Can you introduce Rana Modir?
I'd be happy to, Dr. Santos. I apologize. For whatever reason, it made me register twice to get in. So Rana Modir has been a clinical dietitian for over 10 years as part of a multidisciplinary team for the past 8 years. She supports patients with advanced heart failure requiring mechanical circulatory support and or undergoing bad implant or heart transplantation to optimize nutritional delivery and achievement of metabolic goals. She has a passion for providing nutrition care in ECMO and cardiac surgery populations and has initiated quality improvement efforts for the CVICU, enteral and parental nutrition practices with the goal of maximizing recovery and survival outcomes. We're honored to have both presenters today, and we'll hand over the presentation to you if you guys are ready.
Thank you very much, Dr. Neal, and be safe driving. Dr. Neal actually had an expertise in nutrition as well, so we really invited him, and would like to get his input as well with the discussion. Thank you. We could start, Dr. Rana.
Great, thank you so much. Catherine and I are really excited today for the opportunity to discuss nutrition and telehealth, current landscape and future directions, including impact on post-op and ICU patient care. So just our objectives today are, I'm going to start by reviewing how to utilize technology in providing nutritional support to post-operative patients in the ICU setting, utilizing a case study example. Catherine's going to take over in the second half, discussing the indication, advantages, and application of telehealth in the field of nutrition. She's also going to dive into special considerations and logistics in the implementation of telenutrition, especially in rural and underserved areas. And lastly, she's going to discuss the future direction of telenutrition. And so I want us to consider this case study here. We have a SICU patient, a 63-year-old male with a past medical history of type 2 diabetes, also high-risk prostate cancer. The patient recently experienced significant weight loss of about 20 pounds in 3 months leading up to surgery. He was admitted for an elective single-port robot-assisted radical prostatectomy. Post-op day 0 to 1 intra-op course was complicated by ileum bowel perforation requiring an XLAP and also repair of the ileal perforation and abdominal washout. The patient was transferred to the SICU, intubated, sedated. Vasopressor agents were pretty high at that point, norepinephrine 0.2, vaso 0.04. He had an OG tube in place set to low intermittent wall suction. Post-op day 2, patient goes back to the OR for an abdominal washout, continues with septic shock, also suffered a PEA arrest, develops oliguric AKI requiring CRRT. So the decision at this point was made to start parenteral nutrition, given the patient was already severely malnourished with significant weight loss and anticipated barriers to adequate enteral nutrition in that first ICU week. So he remains hemodynamically tenuous, MAPS 55 to 60, lactate 4, but overall tolerating vasopressor wean norepinephrine down to 0.12 mics per kilogram per minute. Post-op day 3 to 4, norepinephrine 0.07, vaso 0.02. Post-op day 5, patient is overall hemodynamically improving, a little bit more stable, norepinephrine 0.06, vaso 0.02, lactate less than 2, MAPS and goal range over 65, OG tube output stable, less than 300 mLs in 24 hours. And so a nutrition consult is placed to start enteral nutrition or trophic tube feeding just at 10 or 20 mLs an hour with the goal to advance as tolerated over the next few days. And so this is a audience poll question. This patient is post-op day 5. They're still on vasopressor support. They're still on CRRT, and they just had an ileal bowel perforation repair. And this consult is placed at 6 p.m., which is outside of normal dietitian hours. And so we likely won't get an answer from the dietitian until the next day. And normally these type of nutrition decisions or discussions are addressed during team rounds in the morning, but this patient had several off-unit procedures that day. So now it's after 5 p.m. and the team just wants to get some sort of enteral feed started. So my question to you guys is, what type of formula are you going to select? You don't have a dietitian there to help. So are you going to select a high fiber standard formula, B, a renal formula given CRRT, or C, a fiber-free standard formula? So I'm going to give about a minute. And Kelly, will I be able to see the answers?
Yes, we'll publish the results
Okay.
at the end.
Great. So 40% renal formula given CRRT, 60% fiber-free standard formula, and 0% high fiber standard formula. This is amazing. Okay. So through my next slides, I'm going to address the correct answer. But what ends up happening to this patient? And so the ICU provider, he happens to be a new resident to our unit. He has not yet received the nutrition support lecture by our SICU dietitian discussing formula considerations in the setting of hemodynamic instability. So he pulls up the formula list and selects the first formula option out of that list. And this just happens to be our highest fiber formula on our formulary, which it provides 15 grams of fiber per liter of both insoluble and soluble fiber. And when he tries to place this order, an order validation alert or safety alert pops up in the electronic medical record system, or EMR, indicating the use of vasopressors concurrently with high fiber tube feeding formulas may increase the risk of non-occlusive bowel ischemia in hemodynamically unstable patients. The use of vasopressors, the patient is currently being ordered or is being ordered for a tube feeding formula that is high in fiber while concurrently on vasopressors. Please select a different tube feeding or a fiber-free formula. Consult your dietitian for any further questions. But the RD is not available in this case, right? And so the provider looks back at the order selection and selects the appropriate formula highlighted in the order validation alert, which happens to be a fiber-free standard formula. So that's amazing. A lot of you guys got that right, which is awesome. Okay. And so, yes, 60% fiber-free, 40% renal formula. Amazing. Okay. So what are these order validation alerts? And so these clinical decision support tools or safety alerts are existing technology within our EMR that can be utilized to aid in improving nutrition care for our patients. So we see these both inpatient and outpatient. We have order validation alerts and best practice advisory or BPA alerts, which I am sure many of you guys are very familiar with. They're often utilized to guide medical diagnoses like C. diff or any medication or lab orders or nursing workflows. They've been shown to improve patient safety, but they're rarely utilized for nutrition support workflows in ICU settings to ensure best practices. And so this order validation alert was actually created as a collaboration between our dietitians, our critical care attendings, and our EMR clinical systems analyst. And so the safety alert is triggered in the setting of specific vasopressor agents. And when a provider is trying to order specific hyperosmotic formulas, such as our renal formula, or any high fiber tube feeding formulas, or any fiber supplements. And so this type of trigger actually has an override option. So it's not necessarily a hard stop, given sometimes we do provide these formulas and these products for more stable, maybe long length of stay patients, maybe on a lower dose vasopressor requirements. But the expectation is when this trigger is fired or when it pops up, some sort of communication should take place with the dietitian about the appropriateness of the formula. And if it's outside of dietitian hours, ideally select the safest formula option that's listed within the alert. And so why do we implement this safety alert? In 2016, we had 6 cases of non-occlusive bowel ischemia in a very short time frame in our CVICU. An internal audit revealed several inconsistent feeding practices among these patients. And one aspect was the formula selection. And so 3 out of 6 of these patients received hyperosmotic formulas or very high fiber formulas or a ton of fiber supplements, which weren't necessarily recommended by the dietitian, and they were provided in the early postoperative period and the height of critical illness. And unfortunately, all of these patients actually died. And so to address the need for optimizing nutrition in this patient population, we created a multidisciplinary QI initiative was implemented. We created a institution-specific nutrition support protocol with a customized order set. It was really a feeding algorithm on how to provide EN and PN in the setting of hemodynamic instability. And formula selection was actually a major aspect of these guidelines. And so here is our customized order set for enteral feeds. And as you can see, only 4 formulas that are fiber-free are allowed on this order set. So we created this in addition to our standard order set, which allowed all of the formulas. However, despite despite this customized order set allowing only 4 fiber-free formulas, and despite a ton of ongoing education to our APPs and our fellows and our residents, the dietitians were also allowed order writing privileges for enteral nutrition as well. These practices were unfortunately still occurring, and a lot of these products were still being ordered in the setting of hemodynamic instability or higher dose vasopressor requirements. And a lot of this was happening outside of dietitian hours. And so we're a large academic medical institution with several teams, residents, fellows, rotating through all 5 of our ICUs. And it was challenging to educate all providers in a timely manner. So that's why we felt this order validation alert was necessary to ensure an additional layer of safety. And where does this come from? So this is actually an Aspen Society of Critical Care Medicine guideline to avoid both soluble and insoluble fiber for patients at high risk for bowel ischemia or severe GI dysmotility. Ideally, we aim for fiber-free or even very low fiber formulas in the setting of hemodynamic instability or higher dose vasopressor requirements. So if there's any concern for impaired or altered intestinal perfusion, your goal is to minimize digestive work. And these high fiber formulas or these hyperosmotic formulas can actually significantly increase bowel metabolic demand. And so why do we care about bowel ischemia, non-occlusive bowel ischemia? As many of you guys know, it comes with a very high mortality rate, over 80%, right? Here are some contributing factors. This is actually more of a rare complication of enteral feeding in your general MICU population, rates less than 1%. We tend to see higher rates in our SICU and also our cardiac surgery patients. Even though rates are overall pretty low, if we can avoid this severe complication by one simple formula selection, we need to ensure this happens, given we can actually save lives with these type of practice decisions, right? And so what are the results of us implementing this alert at our institution? And so one of our dietitians actually evaluated how effective this alert was to improve ordering practices. And she just presented this data actually at the Aspen conference in Tampa, which was exciting. So this alert was triggered 220 times in 59 patients in a 3-month period. And per dietitian review, 81% of these triggers actually resulted in no changes to the formula, but per analysis, this was actually appropriate. Some of the most common reasons were the vasopressors were listed on the MAR, but not actively being utilized, or the unsafe formulas were listed on the MAR, but actually being held per RN communication orders. 19% of the orders were adjusted appropriately to safer tube feeding formulas. And again, we found majority of this impact occurred outside of normal dietitian working hours. And so what did we learn? We learned it actually is a great idea to involve your dietitians in nutrition support, QI projects, or any EMR workflows. They can support implementing existing technologies within your EMR to drive best practices for nutrition support and also ensure the nutrition recommendations are actually being implemented. And so back to this patient. Okay, we're post-op day 10. Enteral nutrition, advanced to goal rate, 65 mLs an hour via a post-pyloric feeding tube. They're weaned off parenteral nutrition. Post-op day 13, patients on full feeds, has onset of significant stool output, BM times 6, requiring a rectal tube insertion. And so we've all been there before, right? We're all in team rounds. The patient develops diarrhea. One of the providers, several of the providers, the nurse says, oh, it must be the tube feeds. Consult the dietitian to change the formula. But often the tube feeding formula really has nothing to do with the loose stools or diarrhea. And so a quick response or QR code designed to help with diarrhea troubleshooting is actually located on the workstation on wheels, utilizing team rounding. And I'm sure you guys are very familiar with QR codes. They're great tech tools for just-in-time learning or to increase team engagement. They're often utilized to pull up references or tip sheets or policies and guidelines, but they're rarely utilized for nutrition-related guidance in real-time practice, such as team rounding. And so our provider scans a QR code on his phone, and he's directed to an institution-specific diarrhea troubleshooting guideline, which lists out several interventions to consider, and majority of them actually have nothing to do with changing the enteral formula. And so one of the first interventions that is suggested is to minimize hyperosmotic liquid medications and convert any of these medications to crushable tablet or capsule form if able. So this tip sheet provides a reference table that you see here with common hyperosmotic liquid medications that you see in the ICU setting and also on the floor. And so why do we care about hyperosmotic liquid medications in the setting of diarrhea? So obviously when a patient has a feeding tube, we convert several other medications to liquid solution or suspension form. And this is for ease of administration or to prevent clogging. Majority of these medications can actually be pretty hyperosmolar and are associated with diarrhea in patients with feeding tubes, especially with post-pyloric feeding tubes. So a lot of these oral liquid medications and suspensions are actually over 1,000 milliosmoles per dose. Several of these and that is due to the hyperosmotic inactive ingredients. So a lot of these medications have sugar alcohols, xylitol, mannitol, glycerol, sorbitol, glycerin. Some of them even have polyethylene glycol, which is essentially a laxative we give to patients to promote a bowel movement. So these inactive ingredients are known to cause or worsen gas, abdominal distension, bloating, cramps, and diarrhea. As little as 10 to 20 grams of sorbitol, which you see this in a lot of sugar-free candies. This can actually lead to GI side effects in healthy people outside of the ICU setting. The small bowel is actually very sensitive to hypertonic solutions or high osmolar loads. the jejunum actually has a osmolarity threshold tolerance limit of about 300 milliosmoles. So if you're placing several undiluted hyperosmotic liquid medications straight into the small bowel, this can actually result in significant osmotic diarrhea. And so this patient happens to be on acetaminophen liquid solution, 1,000 milligrams every 6 hours. So let's do the math. Each dose is about 4,000 milliosmoles, and they're getting this Q6 hours. So that's 4 doses a day, right? So that's a total of about 16,000 milliosmol of solute coming from just one liquid medication. And what did I just say about the jejunum, right? There is an the ideal osmolar loads are less than 300 milliosmoles. And just to show you an extreme example of this, because some of your patients can be on 4 to 6 liquid medications at once. So let's do the math here again. Let's just say the patient's receiving acetaminophen solution times 4 doses, multivitamin solution times 1 dose, ferrous sulfate solution times 2 doses, and gabapentin liquid solution times 3 doses. So that's a total of about 56,000 milliosmol of solute of solution every single day, which is significant and often overlooked when we're talking about diarrhea. And just by converting one of these liquid medications can actually help to improve diarrhea. So for this patient, post-op day 14 to 15, the acetaminophen was transitioned to crushable tablet form. Rectal tube output improved over 2 days, and they were able to eventually remove the rectal tube. Okay, so moving on, post-op day 16. Now this patient is experiencing excess enteral nutrition interruptions. And you guys know this is a common problem in our ICUs and also on the floor. So the daily goal volume is 1560 mLs a day, but this patient's receiving an average 800, 900 mLs of enteral feeds every day due to all these interruptions, leading to inadequate calorie and protein delivery, meeting less than 80% of nutrition needs for 5 days. So what can we do about this? And so a volume-based tube feeding strategy is actually a great way to compensate for all of these feeding interruptions. This is another great tech tool that can be incorporated into your EMR system by embedding a catch-up calculator into your flow sheets for ease of use. And so this tool allows the nurse to adjust the goal rate every hour with a catch-up calculator built into Epic. And I'm going to show you an example of how this calculator works. And so if the goal volume is 960 mLs, if they're on the standard rate base, they would just be getting 40 mLs every hour, right? Well, with this calculator, it's actually leading the nurse to adjust the goal rate to 60 mLs the next hour, and then 80 mLs, and then 100 mLs, and then 120 and 140. And normally we don't see the calculator ramp up this aggressively, but I just wanted to highlight and show you how the calculator works. It's a pretty aggressive feeding strategy, so you do want to make sure your patients can tolerate higher rates of feeding. It's ideal for hemodynamically stable patients, not at risk for refeeding syndrome or any enteral feeding GI intolerance. And when we implemented this volume-based tube feeding at our institution, it actually resulted in improved nutrient delivery when compared to the more commonly used standard rate-based feeding strategies. So 88% of our volume-based tube feeding group were able to achieve adequate nutrition, and they were able to do this in those first 7 ICU days, which are historically the most challenging phase to feed patients, while only 36% of the traditional standard rate-based group were able to meet or achieve adequate nutrition. So we have this overall improved nutrient delivery. So back to our patient. We're now post-op day 20. Their patient is now in what we call a chronic critical illness state. He's finally receiving adequate nutrition via volume-based tube feeding protocol, meeting over 80% of calorie targets. But now the patient's developing pressure injury wounds, and the nutrition-focused physical exam reveals significant muscle and fat tissue wasting. And so, although we have these great tools like indirect calorimetry to assess calorie needs, we still need to continuously monitor for signs of both underfeeding and also overfeeding. And unfortunately, underfeeding is actually way more common, especially in the chronic critical illness state or for your long length of stay patients. There's several factors which can actually impact energy needs. And so for patients in the ICU over 3 to 4 weeks, the trends in muscle and fat tissue depletion can be a very helpful guide or a way to evaluate response to nutrition interventions. What are these nutrition-focused physical exams? And so as dietitians, we're actually trained to evaluate muscle mass and fat stores, fluid retention, and micronutrient deficiencies via these exams. We see them both inpatient and also outpatient. And we utilize these variables in our nutrition assessments to evaluate for malnutrition, or if malnutrition is improving, or if it's getting worse, and also as a tool to guide for nutrient adequacy. But unfortunately, these tools can have some subjective errors. And so although we have definitions for moderate and severe subcutaneous fat or muscle wasting, every dietitian might have some slight variations in how we practice. Additional factors which actually may skew accuracy is the position of the patient. So if the patient has one shoulder that's shrugged, but the other is not, that shrugged shoulder may actually show more clavicle muscle wasting where the other might not. Also have to consider these patients can have several lines and tubes and tubing and other devices such as compression leggings or stockings, and this can actually skew how the muscle and fat tissue wasting appears. Also have to consider fluid overload. This is a major issue in all of our patients, right? They can significantly limit the assessment of muscle mass and also fat stores, and our patients can be volume overloaded from head to toe, which can be very limiting. So do we have any more objective methods of evaluating for muscle mass or for fat-free mass or any body composition trends? Yes, we do. But to date, majority of these tools are actually utilized in research settings. So we have our CT scans, which we can assess at the third lumbar vertebrae, and several sites are already doing this internationally. Ultrasound machines, which are portable and it can actually be brought to the bedside for evaluating skeletal muscle tissue trends. We also have bioelectrical impedance. So these tools have been shown to be useful, but still have several factors which can skew accuracy, which again, fluid status is one of the main things. But our hope is future routine clinical practice actually includes these tools to measure skeletal muscle area, skeletal muscle density, or also index, really to allow for a more objective measurement when we're evaluating our response to nutrition and physical activity interventions. We also now see new novel technologies being developed to enhance how we assess, deliver, and monitor enteral nutrition adequacy and tolerance. So this recent smart enteral feeding system, it was just developed. It's not currently available in the US. And so this particular smart system, it's actually a nutrition management feeding platform. It includes a console that continuously tracks nutrient delivery. It can actually detect any interruption in feeding and automatically compensate for these interruptions. So it's essentially a volume-based tube feeding integrated into the platform. It also has a continuous measurement of resting energy expenditure. So it's basically a mini indirect calorimetry also integrated into the platform. It also has a smart sensor-based feeding tube, which can detect gastric reflux and also control for tube positioning. So this is really cool. And our recent 2023 analysis of this nutrition platform or system has revealed actually decreased length of stay, decreased vent days, and overall improved nutrient delivery when compared to the control group. So this might be the future in how we integrate technology in providing enteral nutrition for our ICU patients. So back to this patient, poor patient. Okay, so now we're post-op day 30. The patient passed the swallow eval, feeding tube was removed, and he's on the floor and he's working on trying to increase his PO intake. And nutrition intake, as many of you guys may be familiar with, is largely inadequate following the ICU discharge. So patients often struggle to meet their nutritional needs with food and oral nutrition supplements alone. Some of the largest deficits occur in those who had enteral nutrition prematurely discontinued and when they're trying to rely on the oral diet as their sole source of nutrition. And so there's several barriers to eating well on the floor. Ongoing NPO for procedures, it doesn't just happen in the ICU, it can continue to happen on the floor. Post-extubation dysphagia requiring modified texture diet. So patients really don't like the puree diets or the minced and the chopped diets, right? or any excess unnecessary dietary restrictions. Like a patient, they don't really need a low sodium diet if they're eating less than 1,000 calories a day. Also, early satiety and also taste changes can be barriers to eating well. The patient now is discharged. He on post-op day 36, meeting about 60% of estimated calorie and protein needs, which really is not that great. The patient's discharged to an acute rehab unit. And during the course of the hospital stay, he's lost about 15 pounds in 1 month, which is significant. After 2 weeks at the ARU, the patient is discharged home. And he has an upcoming appointment coming up with the surgery team. And so, how can we ensure that proper nutrition follow-up is implemented as the patient goes from the ICU to the floor, and then that early discharge recovery period when they're at home after the rehab unit or the skilled nursing facility? This patient is malnourished with suboptimal PO intake. They're being discharged on a regular diet. They're not being discharged on enteral or parenteral nutrition. So there's really no formal process for outpatient RD follow-up for these patients, right? So several referrals are often sent for outpatient follow-up, but they're predominantly med-surg related, right? So general surgery, nephrology, oncology. Inpatient dietitians, we do recommend outpatient follow-up for malnourished patients that may not be eating well, but this process is not always automated and it's not consistent, right? And so, what is the ideal state? With a growing ICU survivorship and increased burden of post-intensive care syndrome or PICS, post-ICU clinics are now being developed with actually an RD on staff. And the RD can work in a hybrid model, both in clinic and with telehealth, where in person they can help with any physical function tests, such as hand grip strength, sit to stand, balance tests, 6-minute walking test. And so this can help to assess muscle composition or atrophy. Also, if their strength is improving or if it's not improving. And so, but until these type of clinics are more routinely available, we should continue to optimize our current tech resources. And here's another example of how to do that when the patient goes from outpatient to inpatient. So the patient logs into his hospital system health-based app to fill out pre-appointment questionnaire, where he is directed to fill out a malnutrition screening tool, which is a 2 to 3 question survey. And so the patient fills out this questionnaire, which is a validated, reliable screening tool to screen for malnutrition, and his score just happens to be over 2, which triggers a BPA alert to his provider to order an outpatient nutrition consult. So this tool was pursued to ensure patients who are at risk for malnutrition or who are already malnourished can have a nutrition consult with timely nutrition intervention. This patient happens to live 50 miles away from the clinic, so a nutrition consult was placed for telehealth with our outpatient dietitian, Catherine.
Thanks, Rana. So before we dive into the outpatient visit, I think it's important to define what exactly telenutrition is. So the Academy of Nutrition and Dietetics have defined telenutrition as the interactive use by a registered dietitian nutritionist of electronic information and telecommunication technologies to implement the nutrition care process with patients or clients at a remote location within the provisions of the RDN state license as applicable. So for our outpatient telenutrition visit, one of our dietitians has made this really great new patient nutrition questionnaire so that the patient can fill it out before the visit. So this asks questions such as diet recall, any gastrointestinal symptoms they're experiencing, what supplements they're taking, as well as what their nutrition goals of the visit are. And this has been very helpful in the telenutrition setting because then if we have this data beforehand, we have more time to spend on motivational interviewing and nutrition recommendations during the visit. So now we're both logged on and there's a view of the patient as well as the provider. So in terms of nutrition assessment for telenutrition, the things that are similar to the in-person assessment is that we have access to the medical record to review. We are interviewing the patient verbally. We might get the diet recall verbally as well. The unique opportunity of telenutrition is that we get to observe a patient's living environment. We can ask them to show us their kitchen, their pantry, and then be able to assess their nutrition quality of life, what types of food they actually have, how much they're actually eating, if they're on nutrition support, kind of gauging their feeding supply availability. In terms of weight, of course, we have medical record weight, but if we need an updated one, we can ask the patient if they have access to a scale, and they can ask their family member or caregiver to assist them as well. In terms of NFPE for telenutrition, of course, it won't be as in-depth as an in-person assessment. And currently, the Academy of Nutrition and Dietetics offers guidance on how to conduct NFPE through telehealth, suggesting that adjustments may be needed, of course, because data to assess all 6 adult malnutrition characteristics may not be available. So the telehealth NFPE is more questions-based. So first, assessing whether the patient or caregiver has the ability to have the video up, have the camera angle up. Is the quality good enough that they can move the video around so that we can assess their muscle and fat stores? If it's over the phone, doing more verbal guidance, asking questions such as, do you find that your face appears thinner than usual? Are your clothes fitting differently? Maybe asking them to look at old photos of themselves to compare. And in order to assess micronutrient deficiencies, we can look at differences in hair, nails, eyes, mouth, and ask if there's any fluid accumulation in their body. And because this patient has type 2 diabetes, in order to address weight loss, in addition to the PO intake and weight, we also want to make sure their blood sugar is managed, because we know that improving blood sugars improves nutrient absorption and a weight gain. And for this patient, because he was technology savvy, he was prescribed a continuous glucose monitor, or a CGM, and the patient was referred to a diabetes educator for remote training. So once he has his CGM set up, he was able to connect his data to our clinic. So this is an example pulled from Dexcom on what we might be able to see during or before a visit. So day by day measurements of his blood sugars, as well as the timestamps, overall trends of blood sugars. And this is really great because we can view the data in real time, as close follow-up is very necessary in the acute post-op period. We can also ask patients to record food diaries, such as using MyFitnessPal, which is a screenshot pulled from here. They can also send photos of their meals and snacks to the provider via secure messaging. We use MyHealth. And photos can be very helpful for patients who do not know how to estimate portions accurately or find filling out food diaries or recalls very tedious. And with this patient, now we have a lot of data. We have data from the continuous glucose monitor. We can match the date and time to the breakfast diet recall that he gave. We can see that around 8 a.m., he consumed a meal that was pretty elevated in simple carbohydrates, which then corresponds with that rise in blood sugar over 180. And then depending on what medications he's on and his blood sugar regime, we can then alter or make recommendations for his breakfast to help blunt the blood sugar response, such as choosing more fiber-containing carbohydrates, maybe focusing more on the protein, etc. And ultimately, with telenutrition, you can see that there is this big opportunity to increase data points to get an accurate picture of the patient and identify areas to target our nutrition interventions. So what exactly are the indications of telenutrition? So Stanford Healthcare, we do have data from the clinical nutrition team from outpatient visits over 3 specific time periods that we were able to compile and analyze to capture the transition from in-person to telehealth care modalities. So the 3 time positions are pre-COVID-19, during COVID-19, and 1 year later when telehealth became normalized. So of the more than 49,000 encounters, while there were statistically significant differences in the demographics data among the 3 groups, the trends within each group remain similar. So the majority of the patients seen in the clinics were older adults, female, non-Hispanic white, had English proficiency, and did not require interpreters for visits. They also tended to have private insurance. Significant findings over these time periods found that compared to telehealth versus in-person, there were increased return patient visits in the telehealth modality. There were fewer canceled appointments. And interestingly, there was a similar frequency of no-show rates. These findings also suggest that patients were able to adapt to telehealth, that there was an increasing demand for telehealth, and that more patients were accessing care to telenutrition. As shown by this graph, you can see that more patients were returning for follow-up visits in the telehealth modality, and there was a sharp decline in in-person visits by year 2, while video visits increased. All patient populations in this particular study were able to adapt to telehealth, as evidenced by no significant changes in demographic trends such as race or ethnicity, language group, and insurance trends over the study period. Further, there is a growing amount of evidence finding that telenutrition is effective for improving dietary behavior of patients with chronic diseases, such as A1C and cardiovascular disease risk improvements for telenutrition, improved diet quality, and decreased BMI. And it's also been found that telenutrition for patients with malnutrition have improved quality of life and increased protein intake when compared to in-person dietetic care in the community setting. So some advantage of telenutrition is that it can help reduce barriers to care for people who live far away from healthcare services and specialists, who have time or access restrictions, or who have transportation or mobility issues. So also, we know that we can see and provide care in the patient home. We can see their food supply, which gives us a teaching opportunity to use food examples that are familiar to them. And we also have the opportunity to incorporate direct-to-consumer technologies, such as the diet recall app that the patient use, blood sugar trackers. There's also blood pressure, fitness trackers, and more. Although there are many advantages to telenutrition, it is also very important to account for disparities between different populations and locations, specifically for individuals in rural and underserved areas, because historically underrepresented groups, rural residents, and older adults are less likely to have access to technology in these areas. We also know that diabetes is more prevalent in rural areas and other chronic disease as well. We also know that there's reduced participation in diabetes self-management, education, and support services, even though these areas are in high need of them. We also need to consider technology, costs associated with the technology, recurring maintenance or subscription costs for digital health technologies, which presents a challenge of reimbursing the patient. Other challenges include patient empowerment to use these tools. They need reliable connectivity and also patient literacy. And lastly, a lot of these tools, it's very important to make sure that the nutrition databases, especially for food trackers, are accurate and reflect diverse eating patterns. So in conclusion, the future direction of telenutrition include leveraging telehealth tools to reduce healthcare disparities, such as finding ways to increase access to technology, which could include obtaining grants and funding to pay for patients' devices, and perhaps gathering data regarding readmission rates, associated costs, and comparing the demographic data of readmitted patients who receive telenutrition versus in-person care. In terms of NFPE, we can continue exploring and researching the best practices. Perhaps we can start integrating technology and data trackers with clinical environments and EMR. And it would also be interesting to see how machine learning and artificial intelligence impacts telenutrition, such as extrapolation of nutrition data from photos of food. And ultimately, it's important to take an individualized patient-centered approach to assess if telenutrition is appropriate, though overall trends and research are positive to support patient care.
Thank you, guys. Before we get into any questions, did you want to go over those last slides?
Yes.
Yes. Thank you for the great presentation. To the audience, do not forget to fill out this session evaluation survey to obtain your CME credits. You can access the survey by scanning the QR code on the screen, or this afternoon, a link will be emailed to all the participants. We are now open, and we open the floor to the questions and discussion. Can I ask a question?
Yeah, go for it, Dr. George.
I'm a nephrologist, and I know that we're addressing all these formulas. If they are standard formulas, how do you when it comes to dialysis, CRRT, where there is a catabolic state and you need extra nutrition, how do you address that? And especially in CRRT, where we need additional phosphates, phosphorus needs are there. How do you monitor the electrolytes and all the other parameters in such cases?
Sorry, can you, your first question was, can you repeat your first question before I go into micronutrients?
So if you have a standard formula, if there are extra needs, being dialysis being a catabolic state, how do you address those extra needs? Like in a burns patient, how do you address that? A person with bariatric surgery, where they have a part of the gut being removed, all those kinds of things, how do you address those nutrition needs?
Well, great question. So the renal formulas are actually designed for maintenance dialysis patients, right? Out of the ICU setting, they are higher in protein, they're phos and potassium and magnesium restricted. They're very concentrated. They're usually around 2 kcals per ml. It's an Aspen Society of Critical Care Medicine guideline to provide standard formulas in the setting of CRRT with standard electrolytes, because as you know, the dialysate is removing at a rapid rate the potassium and the phos and the mag, and so we provide standard formulas for CRRT, and often these patients need additional things on top of those formulas in the setting of CRRT. So we're giving them these also often protein packets, and sometimes we're giving them every 4 hours, every 6 hours, because protein needs can, as you guys know, can be anywhere from 2 to 2.5 grams per kilogram every day. And so we're giving that standard formula to make sure we're giving all those electrolytes and everything, but then we're having to add those protein packets on top of that. In terms of micronutrients, and so there's a growing body of literature about, in the last couple of years about this, the trace elements being a major concern for our long-term CRRT, the zinc, selenium, and copper deficiencies that can occur for long-term CRRT over 7 to 10 days. And so you're seeing a lot of institutions proactively actually adding like regular multivitamins in addition to standard formulas, or routinely checking for these like on a weekly basis if they've been on CRRT for a couple weeks. We have a lot of things that can skew accuracy of these labs though, right? So zinc and selenium and copper they can be skewed by the inflammatory status. So we have to be careful about interpretation, but so there's a bit way more closer monitoring and watch of these elements now in terms of making this a more routine in practice. Because I can say 5 years ago, I wasn't checking zinc status, I wasn't checking copper, and now we're seeing all that data coming up that even on patients receiving full adequate nutrition, they still develop these deficiencies. And so, we have implemented a kind of a mini protocol in our ICUs where after 7 to 10 days on CRRT, we do start to routinely check deficiencies and also add a multivitamin that is enriched with trace elements. Did I answer your question? Sorry.
Yeah, yes.
Yes, that's an excellent answer. And I learned a lot, from this discussion, the hyperosmolar, liquid meds, because we have a lot of patients on tube feeds, and most of them having diarrhea. And you're right, we always blame the tube feeds. And I like the QR code. I'm gonna steal that, technique. I think that's excellent. Having a QR code, knowing what are the other sources, or causes of the diarrhea. Usually, hey, is it C. diff? And the next thing is, well, white count is normal. It's not, patients not having fever or any, sign of infection. Probably it's the tube feeds. So it's the tube feeds, right? But thank you for enlightening me on that one. And also, you touch on the subject on a lot of interruption in tube feeds. Up to now, there's a lot of ICUs that I've been throughout the United States wherein they still stop feeding, for some procedures. And we all know that the data out there is, if they are post-pyloric, you don't even need to stop the tube feeds. I saw operations being done that is not, that they still doing tube feeds, especially orthopedic procedures. So I don't know. What do you think, Rama? When could we change, the current practice? When will we start adopting this current, clinical practice guidelines? I knew you're doing this in Stanford, but that's not, as you know, not, being done throughout the United States, even in outside countries as well.
Oh no, we still have barriers in our institution with trying to hold feeds at midnight. It's still a thing, and it's we do have the data showing that there's no adverse outcomes, especially with your patients with a protected airway if they're intubated, right? Why would we be needing to at least pausing the feeds right up until the procedure, right? And so what I have learned is that this really needs to be kind of an institution specific kind of QI type project, because there's so many different departments that are involved in this problem, right? You have so many, how many different, you have your IR department, they're going for procedures all over. And maybe these departments might have, or even like a right heart cath, or these random things where they're making them MPO. Or the case gets bumped. We've all been there. The case gets bumped multiple days, and all of a sudden they're like malnourished. And so I feel like it has to start within and really have a discussion about and getting everyone on the same page in all the departments in terms of going through the data. It only takes 5 patients, like this, in terms of case study analysis, and like these 5 patients had so excess interruptions leading to these massive calorie and protein deficits, leading to malnutrition, longer ICU, longer hospital length of stay, and coming together, looking at the evidence and really developing an institution-specific plan. I feel that's what needs to happen, because a lot of us have this outside data. We might be sending publications to each other, but really to make an impact and to make change, we have to get everyone in the same room and really have a discussion. And because things that you would never think of happen, or people's opinions on tube feedings are revealed, where you never would think that people were nervous to feed, during these procedures, or the nurses have different opinions. So everyone, it's really, I felt like getting everyone on the same page and having discussion about it, and really trying to do more of a quality improvement initiative is really a good place to start.
Yes, actually, one of the projects we do is because of this frequent interaction, we actually increase the tube feedings by 10%, as a flop factor, so to counteract the interruption. However, I don't think it's not enough, because as you mentioned, there's a lot of bumps, and anesthesia will not induce your patient if they knew you have tube feeds going on. They will actually suction things out even,
Right.
and I think it's just a waste.
Right. And so even the volume-based tube feeding is a consideration. They're going to get a lot of feeding in a smaller period of time. And so the person who developed that at our institution was actually our SICU dietitian, and she uses that a lot in the SICU. Some of your trauma patients can actually tolerate those higher rates, right, of tube feeding rates. And so so I think that is a good strategy if your patients can tolerate the higher rates, but also really, going towards the path of policy change, like having some sort of like discussion and like look at the data, and also a trial period of like, let's just pause the feeds right before the procedure, and actually track safety outcome data on that. And so like, I think every institution is dealing with this. And we also still struggle with that. And what we found was it was really difficult to get everyone in the same room at once. And, so yeah, it's a challenge.
I think it's a problem everywhere, and I agree with you. Probably it will just take some time. I have a question for Catherine though, because this is about telemedicine. Have you used telenutrition in the ICU or in the floor? I knew there's only limited amount of RD in the institution, and they have to go with how many beds now? 500 plus people. I think it's very selective though. I think. The referral to nutrition, but how do you track, or how do you leverage nutrition in the hospital-based setting?
Yeah, great question. So I do recall during the pandemic, if the ICU patient had to be quarantined and we obviously can't go in, the dietitian could just do a video visit, or the nurse can help set up like the interpreter, monitor, or just like a video, so that the dietitian would be able to talk to the patient or the caregiver or whoever's in that room, and also asking other interdisciplinary members who are in the room to help kind of adjust the video in order for us to look at the nutrition focused physical exam.
Was there a study showing that they're kind of equivalent being there in person versus virtual? And the other thing though is some people will say, well, it cannot be billed on, I cannot bill for this visit, so why will I do it? So is telenutrition billable services?
Rana, do you know for inpatient, like if a person is inpatient and receiving telehealth services?
Yeah, no, our inpatient is not the bill. We don't have the billable aspect inpatient, but outpatient, obviously that's what all of you guys are doing that, correct?
Mm-hmm.
Yeah. But no, I mean, Dr. Santos, do you mean like having an outpatient dietitian talking to the patient inpatient via telehealth?
Yes, ma'am. Yes.
Oh, wow. No, yeah, we, during COVID, the majority of our inpatient dietitians, we were doing a lot of our assessments remote, but we're obviously baked into the cost codes of the hospital and the department. And it's not, every encounter is not billed like they would do in the outpatient setting. But our leaders were able to set up, so we were able to do all of this remote in order to make sure we were continuing with the same quality of care. And yeah, so we were on site maybe once or twice a week, but majority of our assessments were remote for like over a year.
And I just asked that because I'm pretty sure, the laws and legislatures are changing, and so this is something probably that, your organization, the Association of, Nutritionists, or the Aspen could potentially, talk to the Congress. Hey, these are billable services. And of course, if you work hard to give care to our patient nutrition wise, I think it should be billed or covered by their insurance.
Definitely. Yeah, we're seeing that same thing in terms of Aspen and like the Academy of Nutrition and Dietetics trying to go lobby, for support these efforts in terms of like Medicare coverage and stuff like that, and making sure that, yes, I am in the future. Yeah, hopefully that's the standard.
Dr. George, Dr. Nigel, do you guys have any other questions? This is awesome, by the way.
Yes, I do have a question. So for example, a patient is transitioned home on TPN. How do you follow the electrolytes and things like that?
And Catherine, please chime in after I'm just talk. So usually when someone has nutrition support discharge, it's actually better because there is a more like automated process for follow-up. They usually have some sort of company that has a dietitian involved that's set up before discharge. And so they're usually monitoring the lights and they're able, like, there's a lot of third-party companies that can do this. And so, Catherine, do you want to talk more about that? Because I know, oh, yeah.
I haven't had as much experience with TPN outpatient, but I have had for tube feeding outpatient. So yes, definitely there are a lot of enteral companies that are involved, very helpful for setting up and teaching the patient and their caregivers before discharge. And then our role for outpatient, we might just be following up on like tolerance and things like that. In terms of their lab panels, I think that they do have standardized like frequency of lab visits so that we can kind of see their lights, or the company managing the enteral nutrition can also see them for adjustments.
Yeah.
We have
Thank
we
you.
have dietitians who specialize in like GI disorders and like major bowel resections and stuff like that work in the outpatient setting that do have their own standards in terms of if the patient's on long-term TPN, how often they monitor certain electrolytes, and and yeah, there is a standard of like care for that process.
All right, this is wonderful. I learned a lot, from this presentation, and this is recorded, so a lot of people could view this, excellent presentation. Hey, Dr. Neil.
I've been
Go ahead.
trying to talk for a while, but you guys have had so many questions that you've taken all of mine. I figured I would just wait till you got done.
Go for it.
Fantastic presentations. I apologize for being slightly late and almost getting hit while I was pulled to the side of the road. I did a couple questions. You mentioned the non-occlusive mesenteric ischemia, which scares every surgeon in the world when they see it once, which is why a lot of us are hesitant to start tube feeds, even though I've done the nutrition fellowship and I sometimes am too. After you changed your tube feed formulas and your checklist and your safety measures, have you seen a decrease in that, or have you just not seen any more, or what has been the improvement? And then I have another question for the telehealth as well after that.
Yeah, with the development and the rollout of our protocol, it was the guidelines really were when to start feeding based on certain hemodynamic parameters. It had different titration methods. So instead of getting to goal rate within 24 hours, it would actually, it's a slower, it's 10 mLs every 12 hours, which is a lot slower. And also more guidelines in terms of when to hold tube feedings, because sometimes the patient would develop distension or bloating, and if they're intubated, sedated, they can't verbally tell you if they're in pain or anything. And so we had more strict measurements in terms of when to hold feeds. And so with this algorithm, we've actually did see improved outcomes, especially with not only were patients getting increased nutrient delivery, but also less bowel ischemia overall. Like the publication that that actually was published in 2022. And our rates of bowel ischemia actually dropped significantly. And I think overall, like it was aligning practices. Like, okay, patients are coming out of the OR like this, and we see a lot of the same reoccurring themes. How are we going to approach enteral nutrition for this patient? And really trying to be like avoiding a one size fits all approach, which can be really common, right? This isn't a severe, septic shock patient with ARDS. This is a post-operative patient that just had their, ileal bowel perforation repair, or a patient who was just, cardiac transplant, 60 units of blood products, on bypass for 10 hours. This is not the same scenario like we're seeing over and over again. We need to be a little bit more careful with feeding these patients. So yeah, if anything, it's made an increased awareness of like, okay, we need to be a little bit more careful. And also we do have the data to show improved outcomes.
Let's make sure the next one. This is my second time using AirPods on a Zoom call, so you'll have to forgive me if I accidentally hang up again. That's fantastic data. Again, as Dr. Santos mentioned, he and I went to residency together, and so trying to convince people to feed is extremely challenging constantly. And so there's always that gap that we work on trying to get caught up on. But once you get behind in the gap, it's extremely challenging to ever get caught back up.
Right.
Regarding the telehealth stuff, um, when you obviously you're checking on patients, and it sounds like primarily they're with enteral nutrition and tube feeds. Does your group have a kind of a similar thing for, like, for TPN and what have you? Are you managing the TPN via telehealth? Because the biggest issue that we're running into at our institution is we can get people out, but then they're kind of on their own to survive in the world. And if we could build some sort of telehealth to check on these people, it'd be a better thing. So I just didn't know if it had been extended to TPN as well, or if it was just pure enteral nutrition.
Yeah, definitely extends to TPN as well. As Rana mentioned, we have quite a few dietitians who work in digestive health and surgical outpatient settings where they do have standardized care on how to follow up for patients with TPN and support them via telehealth.
I may make my metabolic support team know that, because once they make their recommendations in-house, they become somebody else's problem until they come back to me later. Final question I have, if it's okay, Dr. Santos, I apologize that it's running late. I can see you. You look phenomenal, by the way, in your suit. Dr. Polk and Dr. McMaster would be proud. They'd be disappointed in me, but I am currently at opening day at the Royals, and so I am not as dressed up as normal. You mentioned having kind of strict criteria to stop the tube feeds, especially in the cardiac ICU with all the pressors and what have you, and the intubated patient who can't talk. And you use bloating as one. The last time I looked at the data, albeit a while ago, gastric residuals was not something that necessarily mattered to, as far as like whether or not it affected aspiration and all that kind of thing, that sort of thing. Are you guys measuring gastric residuals as something that you kind of choose whether or not to continue feeding or not? Have you been able to convince the nurses not to check them, because inevitably they get checked and then somebody has to do something with that data? Even though, again, the last time I looked at it, albeit a while ago, it didn't matter. So my question is, what do you guys do with gastric residuals? Do you check them at all? And if you check them, what do you do with the data?
Great question. So yes, agree with you. The data, and actually, it's actually a guideline not to utilize gastric residuals, because in terms of like outcomes, it doesn't matter in terms of aspiration or GI outcomes. And also, we do see some doctors in the clinical nutrition world saying you really need to maybe continue utilizing it for very unstable, hemodynamically unstable patients, maybe being fed gastrically. But so we actually phased it out of our hospital. It's actually a policy that you cannot check gastric residuals. So we no longer implement this in our hospital since I've been at Stanford. So obviously in special considerations, they do have the option to do it, but it's policy. So the nurse can't even really do it. But I will say this, sometimes what we do is this combined post-pyloric feeding with OG tubes set to low intermittent wall suction for the early post-op patients. And we do use that 24-hour gastric tube output trends as a lever to assess tolerance. So if, output's been less than 500 mLs every single day and we're advancing tube feeds, all of a sudden that shoots up to 1.5 liters. That is good information for us to pause the feeds, maybe get a KUB. But if sometimes what ends up happening is that post-pyloric tube was just pulled back in the stomach and basically OG tube is taking everything out. So we still do that combined method for our surgical patients, I feel like that output is actually helpful if I can't talk to the patient. So that is in our algorithm. We say if there's a marked increase in OG tube output trends or NG tube output, then you should investigate further, right? If it's been less than 500 mLs every single day and it just shoots up, you don't want to ignore that. And that was something that was happening. So with the before we had our guidelines, the patient was having massively increased NG tube output, and the feeds were just kept going. So we
Rana,
don't
I think I
so
think I'm going to, get a video of when you said in Stanford we phased out, residual
Yeah.
testing, because I will probably get a version of that, statement, because that is a struggle with me as well in the ICU. They keep on telling me the residual volume, and I told them no, you don't need to measure those, and I think all over the country they're still doing that though, which is. We need a lot of education to our nurses.
Right.
Yeah,
And
I know.
again, it goes back to just, the kind of the dogma of whatever, because the nurses that train the nurses tell the new nurses they have to check these regardless. And so my question to you is going to be, how in the world did you get a policy that says you can't check gastric residuals? How did you get that through, I don't know, patient safety and the IRB and all that kind of stuff? Just because, like, I could imagine me trying to roll that through, and the amount of meetings and that I would have to have just to, about whether or not I was still sane. So if we could get, Stanford does X, in like a sound bite, that may help mine and Dr. Santos's plan in the future. But no,
It's
fantastic.
yeah, multidisciplinary. Like our dietitians are involved in these enteral nutrition policies that need to work together with the nursing policies, right? And yeah, we do have surgeon, anesthesiologist, critical care also on our committees for enteral nutrition and safety and stuff. And so it's like everyone again kind of getting on the same page and like going through the data. And then since they phased it out, there was no like difference in outcomes. And so I think yeah, so I think again it was really about making sure you have a lot multidisciplinary representation that are developing these policies, and the policies are renewed every so many years. So that's an opportunity where you guys all get in the same room and be like, okay, do we need to update this to align with current evidence-based practice?
All right, we went over time, but it's worth the time. Thank you for the fantastic presentation and discussion, and thanks everyone who joined us today. Dr. Neil, Dr. George, thank you. Aaron, thank you. And thank you, Dr. Stewart. In our chat box, there are some, references there. That was courtesy of Dr. Stewart, our librarian, and to our wonderful team that makes this series possible. We would like to present you both our, Texla TRC Challenge coin for your pioneering contribution in advancing telehealth in nutrition and in healthcare in general and in the ICU. So thank you, Catherine and Rana. It was wonderful to have you with us today. Could we advance the slide though? Thank you.
Oh, yeah, sorry, go ahead.
Yeah, be sure to join us in our next presentation on Friday, April the 26th with Dr. Yohan Butler-Tuba. More information and registration link will be available on our website and social media channels. Thanks again for joining on today. Have a great day.
Thank you, Rana, and thank you, Catherine. This is awesome. Thank you.
Thank you so much for the opportunity.
Thanks
Have
for
a great
having
day,
us.
guys.